Welcome to the Scoop Educational Masterclass brought to you by the National Association of Nutrition Professionals. Your host is Andrea Granson, the NANP's Educational Program Specialist. The information presented in this masterclass is for educational purposes only. Please note that holistic nutrition professionals do not diagnose, prevent, treat, cure, prescribe, manage, or heal diseases or medical conditions. They are also not licensed in any state and work with clients, not patients.
Hello, I am Patricia Kaufman. I am going to discuss with you today on how to use evidence to inform your decision-making in the healthcare area and as a nutritionist. So a couple of disclosures before we begin. I'm Dean of Integrative Health and Nutrition at ACHS. I do teach at NUNM. I am a CNS supervisor. I'm part of the editorial board of Journal of Integrative Nutrition. The opinions are my own, and none of the information should be construed as medical advice. So today, our learning objectives are understanding the types of studies, identifying the types of studies and how it informs decisions, evaluate how studies are valid and reliable, and understanding if they are valid and reliable. And then we're going to use what we know, and so we can use it to create evidence-based protocols. So if we start from the basics, we will go through each of these in a second. We're going to talk about the research evidence pyramid for healthcare sciences, and that can help guide our decisions on what type of studies we use to inform our practices and protocols. We'll discuss if most healthcare research is false. Some believe it is. We'll look at the Equator Network, which is a guidelines for ensuring credible, reliable research. We'll define what it means to for an article to be peer-reviewed, and we'll dive in just quickly on ways to develop a research question in case you are interested in doing research. So if we look at the health science research pyramid, you'll see this pyramid is a little bit different and depending on where you grab the image from. But the important things to remember is that expert opinions are, of course, the lowest level of evidence. And as we get up to the top, this is the highest level of evidence. So case control and case studies, we'll look at these in a second. We'll look at cohort studies. We'll look at randomized control. And then this particular diagram doesn't have meta-analysis, but systematic reviews, meta-analysis are at the top on the pyramid. Literature reviews fall under this background information. So is most healthcare research false? Maybe, maybe not. And why can it be false? The method section of the study could be flawed. It could be the method section could be too restrictive. So in the method section, you have an exclusions and exclusions, who's going to participate in your study. And those can be too restricted so that it's not a representation of the population and cannot be generalized to the population. The sample size might be small. A lot of times individuals I work with, they'll say, well, the sample size are small, so the study is not valid. But in randomized control trials, the sample size tends to be small because it can be very expensive for a larger sample size. So it's not uncommon to have a sample size of n equals 30. The intervention, what does the intervention look like? Is it realistic? And is it in humans or is it in mice? And is it bias-free? So the different types of research can help us remain more bias-free. So we'll look at that. And then if a researcher is doing a literature review, there's no systematic way in a literature review that's documented. So another researcher can't come in and duplicate a literature review. So it's very common for literature reviews to be more skewed towards the position of the researcher and not what is known in the field. So you can, what I mean by that, you can exclude studies from the literature review that may not show a positive result. And then we need to know what testing methods were used and how the studies were analyzed. So we'll look at all of these in a second. And then the other thing is to see if the research was funded. Not all funded research is bad, but sometimes funded research can skew the research question, can skew what's analyzed, skewed who's included and excluded in the study. So that's always important to look at. And then if there's any conflicts of interest for the researchers. The Equator is a network. It's not a database. Many people think it's a database like PubMed, but it's not. The purpose of it was to ensure that studies are more rigorous, that they're transparent, they're reliable, and they're credible. So it offers guidelines for each type of studies and a checklist for each type of studies to ensure that the researchers are following these guidelines. And you can use these same guidelines to validate then if a study is credible, reliable, and transparent. So again, it's not a database, and we'll look at the different types of, these are the guidelines next to the types of studies, and we'll look at those in a minute. So what are peer-reviewed articles? So many times people will say, well, that's not from a peer-reviewed source. So a peer-reviewed article is the evaluation of a manuscript by scientists for a specific field to ensure the accuracy. So I'm a peer reviewer for a couple of journals. And so my job when I get article to peer review is to go through the article and see if it's valid, accurate. And I'm only given articles that that it's in my field and that I have some type of specialty in. It also, the peer reviewers are responsible to look at the methodology. Is it accurate? And did they validate the findings of their research question? And most journals, scientific journals, follow a peer review process. For the journals that I peer review, I have a specific process. I have to answer specific questions. And so there is a process in that. And it also ensures IRB is completed if needed. IRB is needed when there's an intervention that deals with humans and animals. So that's always, the peer reviewers are responsible for ensuring that there was an IRB was completed, and then to assess conflicts of interest as well. Is peer-reviewed literature 100% true? No, not necessarily. Even though it goes through a peer review process, things can be missed. Why? Because there's certain studies that fit the needs of the publication. So even though it's not a very credible or valid article or study, it can get that process can get skipped by some journals, so it can get published. The reviewers are not always experts in the field. The study's funded, and then the peer reviewers just kind of go through it really quickly and don't really assess it. So the criteria is subpar, and the reviewers' analysis of the study is subpar. So let's look at research questions, ways to develop your research question. A researchable question is an uncertainty about a problem that can be challenged, examined, and analyzed to provide useful information. So it's adding information to the knowledge to the field. So one common method that is used, and I have used it often, is called the PICO method. And this helps inform your research questions. So the PICO the P stands for population, so that's your demographics of participants. You either have the intervention or exposure in a randomized control. You're going to have an intervention in an observational where you're just observing someone's activities or way of eating. That's an exposure. And then you can have a comparative or a control. So the control group in an intervention study is typically the placebo, or it could be the standard of care, or it could be a control group of someone not exposed to, like, say, cigarette smoking. The outcome is the primary outcome that the investigator is interested in. It is not the results. It's what they want. They're hoping to achieve the outcome. Like, they're hoping to see what the HbA1c is based on intervention of 2,000 IUs of vitamin D. That is the outcome. The outcome is HbA1c. It's not if it did it or not. If it's not that it reduced it by 20%. So it's just the outcome. So this is, you usually find this, the health outcome or the outcome that the study is talking about or interested in the introduction, usually the last paragraph of the introduction of the study. So this is an example of the PICO method: population, adults with type 2 diabetes who live in the United States, intervention, 2,000 IUs of vitamin D, a comparative placebo. So the other group was given a placebo, and we're looking at the outcomes are HbA1c, fasting blood glucose, and vitamin D. Another method that if we look at an observational study, we can look at adolescents, the populations at adolescents 10 to 19 years old. So the exposure is their vitamin D level, so their deficiency or compared to sufficiency. So nothing is given, it's just looking at levels. The outcome here again is not what if deficiency was associated with a 20% decrease in arterial or increase in arterial pressure. Instead, it's just looking at what outcomes it's interested in: arterial pressure, lipids, blood glucose. And again, the study design is observational studies. In observational studies, as we'll see, there is no intervention. You're just observing, thus the name observational. So if we look at scientific literature review, remember that's the bottom of the pyramid. So it can add to the scientific knowledge to the field, adds scientific knowledge to the field, but it can be very helpful because it's summarizing new findings that we don't always have time to review each study and see what's happening in the field. And so a literature review gives us a chance to look at an overview of what's happening. But again, there is no methodology, there's no statistics. So with no methodology, another researcher cannot come in and duplicate the study. And it's not categorized as a primary reference. Again, it's an overview of a topic. Cons is difficult to replicate, and it can be biased, as I indicated before. What do you include in a scientific literature review? You're going to include your purpose statement. What is the topic? Your literature search. Now, again, it's showing the databases and it has a search criteria, but it's not given the literature search in a literature review is not telling you the search queries. We'll see that that happens in systematic reviews. So it gives you a critical analysis of the information. It's evaluating what does the evidence tells us, what are the limitations, and then you need to understand if it's bias-free or not. So if we look at observational studies, there are case series and case reports. So case series is usually 3 case reports on the same topic. Then we also, case series and case reports are not always put under observational studies, but sometimes you will see it. So in this case, I did put it under observational studies. We have the other observational studies are cohort, also called longitudinal studies, case controls reports, and then cross-sectionals. So we'll look at each one of these. So a case report, case series, what are they? They're individual or small groups of clients. They're a narrative. They're looking at the diagnosis, symptoms, conventional and integrative care, and they're just looking at what worked for that client or that group of client. Sometimes they're peer-reviewed in journals, sometimes not. Why do you use case reports and series? It helps for new and rare diseases and conditions, and then you would follow up with a different type of study. It helps assess adverse events or adverse effects. Adverse events are, say, like heart attack. Adverse effects are more like diarrhea, that a drug is given, like chemotherapy the adverse effect is diarrhea. It can be used for professional education and a basis for future research. So we have some strengths and limitations. Sorry, this should say events. So report on new observations and events. foundation for generating hypothesis, in-depth narrative, educational tool. But what are the limitations? There are no analysis, and it cannot establish cause and effect relationship. And then it cannot be generalized to the population. Why? Because it's usually n equals 1 or n equals 3. And so it's so small that the number is so small that it can't be generalized to the population. And then there are potentials for biases. Here are the CARE guidelines. The CARE guidelines are the Equator guidelines for case reports. So you can see that there's a number of different steps. And so if you're reviewing a case report, you might want to look at the CARE guidelines to see if the authors actually followed the CARE guidelines and to know if you feel the case report is valid. So if we look at cohort studies, we have observational studies. What is the purpose of this? Aim is to analyze. It can use statistics to examine the association between an exposure and an outcome. It's the exposure, right? There's no intervention here. It's not experimental. Individuals are studied at real life environment, so that can be both a positive and a negative. Positive as that they're living their life, and so you know what's working and what's not working just by observing them. The difficulty thing is there could be confounding factors. So for instance, someone may have a reduced risk of mortality because they eat 3 servings of vegetables. But typically those people that eat vegetables might also exercise, right? So is the exercise what's decreasing the risk of mortality? Observationals can be gathered both prospectively, which is typically a cohort, retrospectively, so going backwards, which is case control, or a snapshot at time, which is considered cross-sectional. So think cross-sectional, one point in time. We have different statistics for observational studies. We have odds ratios. So an odds ratio greater than 1 is the event is more likely to happen in the exposed than the unexposed. The opposite if it's less than 1. And then relative risk also indicates the probability of something happening versus anything else happening. And those are used in cohort studies. And the same rules apply as above. So if we look at a cohort study, our exposure happens, then we follow the individuals throughout time, and then we look at the outcome. So the reason why it's known as a longitudinal, because it requires follow-up, which can be costly and difficult because you can have a number of people that drop out and that you don't have follow-up on them. It compares outcomes between groups based on exposure. So plastic, smoking, type of diet. And it provides information on how the exposure are associated with an outcome over time. So outcomes can be positive or negative. So don't always think of an outcome as a negative. So if we look at cohort studies, we're using relative risk again. So a relative risk greater than 1, the risk of the outcome is more likely to happen when exposed to something. And the relative risk less than 1, the risk of outcome is less likely to happen when exposed. So, okay, let's move on. And then, so cohort, remember it's prospective. So you have exposure or those that are not exposed, and then you're looking at the outcome, percent outcome. And remember the 2 groups exposure is not identical, right? So the exposed, they could eat 3 servings of vegetables a day. Those that are not exposed could be they don't eat any vegetables a day. And what's the outcome? The outcome could be decreased risk of mortality, and the outcome for the not exposed could be increased risk of mortality. Or my example here that I give about type 2 diabetes. So it's important to understand the difference between odds ratio, relative risk, and hazard ratio. So these are proportional. And so a great increase or decrease in these relative measure may still be clinically irrelevant. So it's always important when you're looking at the data to say, is this really clinically relevant? For instance, if a 1 milligram decrease in, or 1 milligram per deciliter decrease in LDL is significant, and the relative risk showed that it was reduced the risk of heart attack. Would that 1 milligram per deciliter really be clinically relevant? Is there something else that's going on that might have also, because of the confounding variables in observational studies, that could have caused that decrease as well? So it's always think in your mind, like, is that clinically relevant? So a small change in these measures may be important if the absolute risk is high. So remember that statistically significant doesn't tell us anything. So always, when you're reporting on if something is statistically significant, always report the data too, so the reader can understand what the change in the marker was, to assess if it was clinically relevant. Okay, so case controls, they examine exposure and outcomes in two groups. So you have your cases and you have your control group. So the participants are matched for age and gender. You look at odds ratio to indicate the odds of a specific event happening versus not happening. And we already looked at what those mean. So remember, case controls go backwards. So they're looking at, okay, there is a specific outcome, and the control group had no outcome. So let's go back and see what their exposure was. And so that's why you would want to do a case control. Cross-sectional, remember, is a point in time. It's used to calculate prevalence. So when you see the prevalence of COVID or the prevalence of type 2 diabetes, they're using cross-sectional information. So it's not incidence. It's not how many were. It's because incidence is the number of cases of a condition over a period of time. And remember, prevalence is a condition, the number of people with a condition at a point in time. So it's that cross-sectional, a point in time. So prevalence, point in time, incidence, condition over time. What are the pros and cons of observational studies? Pros, it can assess multiple outcomes, can establish a risk, inform about a treatment that would be maybe possibly unethical in a randomized control, can use when blinding is not possible. What's the cons? It's harder to conduct. You have the time. It can be years. You have those dropouts, like I indicated, in a cohort. You cannot establish a cause and effect relationship. Why? Because there's no intervention. You can only establish if there's a significant association, not X caused Y. It's difficult to control for because of those confounding factors I indicated. And then you have to understand if there is always self-reporting, so that can be an issue as well. Are you getting accurate information? Overview of observational studies, it focuses on a group of individuals, and usually they're quite large. So randomized control, remember I said it could be small. Observational studies are usually in the thousands to 10,000s, if not even higher. Its aim is not to describe, but rather to analyze. It uses statistics. It's not experimental. Individuals are studied in real life environment. And then again, observational studies can be cohorts, which is prospective, retrospective, which is case control. And sometimes cohorts can be retrospective as well. And then the snapshot of time is the cross-sectional. So now the gold standard randomized control studies, an intervention is given to humans. And then the intervention, let's say, is a supplement, acupuncture, diet, and it's controlled, right? So I'm giving you, as a participant, 2,000 IUs of vitamin D, or I'm giving you a specific type of diet to follow. The diet one is a little bit harder because people don't, depending on how the intervention is done. It's a gold standard of studies. It can be double-blinded or single-blinded. Double-blinded means that the participant and the researchers don't know who's getting the intervention versus who's the control group or the placebo group. And the researchers and those that analyze it don't either. And of course, those that are getting it don't know what they're getting. They don't know if they're getting the intervention or the placebo. It has different types of statistics. So for an intervention for a randomized control or a randomized control study could have an example of 200 milligrams of calcium magnesium glycinate, and the placebo group receives a sham. And the duration is 12 weeks for both groups. So we'll look at that in a second. So the guidelines for the equator are much more extensive than that of case studies. So you can go through and look at the checklist to understand if the randomized control study is valid and transparent. Why is randomization important? It helps tease out those confounding factors. Participants are blinded to what group they assign to. The two groups are identical, and the randomization happens after the selection process. So usually there's a selection of like, okay, we interviewed 100 people, we're going to select 50, then they get randomized, because they're supposed to be, your inclusion is going to get you a group of participants that are very similar. And so if you're doing it properly and then you randomize them, it shouldn't matter what group they are randomized to, so that the groups are still equal, have the same demographics and age, and thus. What are some pros? Strongest study design can establish causality. So a cause equals effect, or cause X caused Y. It has randomization that minimizes the confounding factor. It allows you to create a big enough contrast between the intervention and control group. It's expensive, like I said before, because you really have to do the intervention. You have to follow them through that 12 weeks. You have to put up a lot of different control mechanisms so that you're recording accurately. The duration is often not long enough. That is the con of it. Why? Because the longer it is, the more expensive it is. And in some cases, you would have fallout from the participants if it's too long, because sometimes it's too regiment of what they need to be doing. The intervention sometimes is not always translatable to real life. It's just not realistic. Compliance of groups can be an issue. And because, for instance, the control group might start eating what's in the intervention food or the intervention food. So then you're not getting accurate data. Choosing the right control can be quite difficult. If it's, of course, a placebo, that's not an issue, but if there's another type of control. And then are the participants representative of most of the people? Can it be generalized? You have different types of RCT designs, parallel designs, crossover designs. The parallel designs mean the intervention group and the control group, they're going side by side each other, right? Both the control group and the intervention group are doing what they're supposed to be doing at the same time. A crossover design means that each person in the study actually crosses over to the other. So for instance, you could have a crossover design where there's half of the participants do a ketogenic diet, and then there's a washout period, usually a couple of weeks. And then that group that did the ketogenic diet goes over to the Mediterranean diet to see if there's a difference. And then the other group could start with the Mediterranean diet, then do the washout, and then move over to the ketogenic diet. So the individual themselves is really the control, which can be valuable sometimes. A factorial design can get difficult because you're usually testing several treatments at the same time in a combination. For instance, like you might have 3 different arms. Or 4 different arms. You might have a placebo arm. So say you have 10 people get in the placebo. You might have the vitamin D only arm, which another 10 people, and then you have calcium only arm, which is 10 people, and then you have the vitamin D plus calcium. So it can get challenging of when you combine 2 different supplements, even though you're doing vitamin D only and calcium only. How do you analyze randomized control data? There's 2 different ways: intention to treat, which is ITT, or per protocol. The intention to treat means that regardless if they started the study and dropped out of the study, you still analyze the results. Versus per protocol means you're only analyzing those that finished the protocol, finished the study. But the intention to treat really reflects true clinical, like, is it true? Like, what's going to happen? And where the per protocol really just shows the effect of the treatment, but it could be biased, right? Because say it's a ketogenic diet versus Mediterranean diet, and those in the ketogenic diet, 25% dropped out. So are you going to get accurate data? Because you don't have the same numbers in each group. So your analysis will be off. It's always important to understand the difference between groups or within group analysis. Between groups, so the ketogenic versus Mediterranean diet, that's more important to study the difference of that versus the in-between group where someone in the ketogenic diet might have shown a different effect or results. So example, participants on a carnivore diet were significantly leaner at the end of the study than at the beginning. Participants on the control placebo diet, so they didn't get a diet, were also significantly leaner at the end of the study. The real way to determine if the carnivore diet was more effective than the control placebo is to measure if participants on the carnivore diet were significantly leaner than participants on the control diet at the end of the study, right? So if we just looked at the carnivore diet and said, oh, they lost weight, well, and then we would think that carnivore diet was beneficial in that. And this, I'm making that there is possible that the carnivore diet has shown this, but I'm just giving an example here. But if we didn't measure it against the control where they also lost weight, we wouldn't know that if the carnivore diet really did cause a weight loss. What statistics are used? We typically use means and 95% confidence intervals, and we use p-values. There are also the measurements of relative risk hazard ratios with the 95% confidence intervals. Means are used for confidence intervals as well. And we're looking at changes in values from baseline as absolute numbers and percentages. And again, the p-value only tells us if the results are significant. And what that means, like say the p-value is 0.05, it is only telling us that there's 95% certainty that the change did not happen by chance. So there's a 5% chance that the change happened randomly, like wasn't the effect of the intervention. So if we look at interpreted in stats, a p-value of equal to 0.049 is significant. Why? Because it's less than 0.05. And this is assuming that the researchers set, and you'll find this in the methodology section, what they set the p-value to. So in this case, let's say that the p-value was set to less than 0.05. This would be significant. A relative risk, of 1.5 with a confidence interval of 1.01 to 1.8. So this 1.5, right? It fits in between this range. So we interpret relative risk as this is a 50% increased risk in X, say in mortality. The larger the range, the wider the range, you're less confident in this number. So it's actually, you want a tighter range and get you more confidence in this number before the 95%. If we look at relative risk of a 0.75, what does this tell us? Here again, it's sitting in this range, that there's a 25% reduction in the risk in X. So let's look at the top of the pyramid, systematic reviews and meta-analysis. What are systematic reviews? They're a comprehensive study of available studies. Those that you found or the researchers found. There could be studies that the researcher wasn't able to find, right? So it doesn't mean that it's all studies out there that exist. You have a clearly stated research question. The process is systematic. So you have a methodology. Think of a methodology as a recipe. It allows another researcher to come in and duplicate the study. So that's why a systematic review is set apart from a literature review, because the literature review does not have that recipe for another researcher to come in and duplicate the study. It has inclusion criteria for the types of studies, and it also does a validity assess against biasness or biases of the studies. Now, meta-analysis does an overall statistical summary. So a systematic review does not need to have a meta-analysis. but a meta-analysis always has a systematic review. So you're going to take your systematic review, and now you're going to put it in, you're going to take this statistical summary of the results, and we'll look at those in a second. Sometimes the heterogeneity of a study, so the differences of the study that are included is quite high. So that doesn't always mean that if the statistical summary said that it was great, you have to look at the different types of studies, because they might have just been not comparing apples to apples to be able to say that that was a good finding. But it reports on a relationship between two variables. It results from the included studies are in standardized effect size, so it helps that. So when to use a systematic review versus a meta-analysis, I mean, well, like I said, meta-analysis, the underlying part of a meta-analysis is a systematic review. So if we look at a research question, what are the effects of almonds on type 2 diabetes in adults? We're going to systematically search for available RCTs. You can do observational studies in systematic reviews and meta-analysis, but the best, if you want to establish a cause and effect, is to do RCTs. And our criteria is going to be published in the last 10 years, written in English, adults, and they measured, each of the studies measured HbA1c. So you're going to summarize the results in a table for a systematic review, and in a meta-analysis, we'll look at it, you're going to use a forest plot. This is the PRISMA guidelines, are just some of them. There's multiple pages of this, but I just wanted to highlight that the PRISMA guidelines is for systematic reviews. There's the risk of bias that I talked about, looking at, you're evaluating all the studies in your systematic review that met your criteria, and then you're doing a risk of a bias assessment. How valid, the valid assessment of the outcome, the valid assessment of the inclusion, exclusion, and there's tools for you to do this. So you can see the black is low risk, and the darker or the lighter gray, which is up on this top, you can see is there's a high risk of bias. The pros and cons of systematic review: it addresses a specific question in a structured, reproducible manner, right? The recipe, you can duplicate the recipe, or the making of something, the making of a cake. It identifies all relevant to summarize and evaluate those studies. The researchers can more accurately identify trends. It can help with inconsistencies in data across studies, and it reduces biases. Unlike a literature review, I can just pick which studies I want to include. I don't have to really go through an inclusion or exclusion. Cons: it's a lengthy process. The methodologies of the studies that you include could have a lot of inconsistencies and if you don't appropriately define your search terms, because remember I said systematic reviews, you're going to give exactly your search queries. Like I used PubMed and I used these search criteria. I report that in a table so others can see what the exact search queries were. But in some cases, maybe you didn't use the appropriate search terms, so you didn't find the types of studies that could have been included. And then sometimes the outcomes measured in each of the studies included in the systematic review could be inconsistent. So if we look at a forest plot, this is what is done in a meta-analysis. And the null effect line means that the study did not show significance. So each horizontal line with a circle is a study. So the diamond is bringing all the statistical data of these studies, these 4 studies above, and saying, is it significant? So it's telling us if it's significant or not. If it crosses the null line, it is not significant. None of these studies showing right here are significant because the horizontal line is passing the null line. The line itself is your confidence interval. The larger the circle, in this case, this is the largest circle, this is the largest study. Where the smaller the circle, the smallest study. Remember I talked about the confidence interval and the range. So this confidence interval has a much tighter range. Some confidence intervals has such a broad range, you can't really say if that's significant or not, even if it didn't cross the null line. This is an example of meta-analysis. So here are the list of all the studies that were included, and we can see the p-values of all the studies, and you're using the standard of errors and the difference in the means to indicate if it's significant or not. And so here's our null line, the 0. And to the left of it, we're showing those that took vitamin D has a reduction in HbA1c percentage, and those in the placebo, if they had a reduction or not. So we can see that a number of studies are not significant. This one is significant, this one is significant, this one, and it has a very small confidence interval. And so, but we can see at the diamond, the overall effect of bringing all the data of these studies together, we can show that it does have a reduction in HbA1c. So some considerations for systematic reviews or subgroup analysis are often carried out. For an example, you might want to look at vitamin D and osteoporosis, but you might want to, the overall study might look at the association between vitamin D and osteoporosis, but you might want to do a subgroup of those that are premenopausal and those that are postmenopausal to see if there's a difference in the vitamin D association with osteoporosis or lack of vitamin D. The quality of the systematic review and meta-analysis is only as good as the studies that you're reviewing. So poor junky data and poor studies is going to result in poor findings or poor results or poor quality of study, I should say. A systematic review of poorly designed studies, of course, is not good evidence, like I said, and a systematic review only captures a few studies is probably not enough evidence to say there's a cause and effect. The meta-analysis of pros and cons, it increases statistical power by pooling the data from multiple studies like we just showed. It provides more precise estimate of effect size. It can identify patterns, it helps resolve uncertainty when studies disagree. It allows for subgroup analysis, and it can generate new hypotheses as well for future studies. Again, dependent on the quality of the included studies, prone to publication bias. Journals only typically like to publish studies that show a positive results. The heterogeneity between the studies can inhibit accurate interpretation. So if that heterogeneity, which is I squared, if that's over 50%, that means the studies aren't very similar. So it's hard to interpret if the results are accurate. You can have differences in study design and measurement, which may limit you from doing that forest plot. And it can mask clinically important differences in overgeneralization. So sometimes it can overgeneralize things. Okay, so our key takeaways today is that, it's best to use that evidence pyramid to guide you, because remember the strongest evidence are coming from systematic reviews, meta-analysis, and only randomized control or a meta-analysis that use randomized control can establish cause and effect. Each type of study has its pros and cons, so it's important to understand those. And it's important to tell us what the data is telling us. What's significant does not mean clinically relevant. That's probably the biggest thing to always remember. And so here's my contact information. Thank you. And let me know if you have any questions.
NANP members can earn 1 continuing education credit for participating in Scoop Masterclasses by taking the corresponding quiz, which can be found in the Learning Center of your My NANP dashboard.